Just wanted to start with a small quote and sort of set the scene a little bit. So I'm in the gym car park and I want to cry. I've been trying to enjoy the gym after having always hated it. I'm working with a personal trainer and I can tell he thinks I'm pathetic and moany. I'm in perimenopause, I have tendon pain and I feel exhausted all of the time. It takes every ounce of energy just to walk in the door. Between his dismissive attitude and my emotional problem relating to exercise and gym, I almost cancelled my membership. Now, this is not a patient of mine, this is a quote I found on a Reddit forum. I tend to do these little deep dives into Reddit and Facebook groups, and you can find these great communities of people who are going through menopause or going through things like knee osteoarthritis group they've got, or sciatic pain or chronic pain, and there's all these groups out there. And it's amazing just how raw and honest they are. And it's a bit like Andrew was saying in the last talk. People, when they've just met you or only met you a few times for half an hour here or there, won't always open up to you. And some of these groups can really kind of get those honest opinions. And this one stood out to me as a really emotive post, but it just shows a lot of the things I'm going to be talking about in a second of why it's so important that we really try and understand some of the barriers that our older adults are going to face getting into a new exercise program. Like this woman here, she doesn't feel listened to, she feels like she's been dismissed, and that's already layered on top of her own beliefs around exercise and her own problems with it. So that's where I want to talk about where we come in as rehab professionals. So imagine there's physios, sports therapists, massage therapists, chiros, osteos in the room. We all have the same initial goal. We've got someone that comes in to see us who has a pain, stiffness, some symptom that they've come to see us about, and they want our help at trying to calm that down and get them back to their normal lifestyle. But I think we've also got a role as rehab professionals to try and guide people in the right direction of how to prevent future issues and try and create a healthier future, a more active future that they can look forward to. And there's a lot more research coming about now that shows the importance of strength training. We could see that a loss of muscle strength could be associated with so many things like respiratory disease, cardiac disease, diabetes, dementia, osteoporosis, sarcopenia, risk of falls. Those falls can lead to hip fractures, and those hip fractures then I think 20% of hip fractures end up in long-term care within a year and they never come back out again. And the research is showing that, but the great news is as well, mainstream media is starting to catch up. We're starting to get a lot more people on the big podcasts, on news channels, and some of the things like The One Show. I saw something recently promoting the message that strength and resistance training and exercise is great as we get into older age. Whereas in the past, strength training might be thought of as something potentially unsafe, and we should probably stick with Pilates, swimming, yoga, which are great forms of exercise, but people did them because they thought they were only options. They didn't realise they could do some of these other things. So it's our role as rehab professionals to try and guide people towards that. If they want to engage with that, we're not going to convert everybody into that. Some people just want their pain gone and they're back to the everyday life. But if we can, that's where we can help kind of guide them through that. However, we are going to face some challenges and barriers as older adults to start strength training, but any other new exercise regime. So I'll talk some more physical ones specific to strength training, but a lot of the psychological barriers, which I'm going to focus on more, don't just take it for strength training. If you tend to lean towards Pilates or anything else that someone hasn't done before, and they're starting at the age of 60, 70, they're not going to jump straight into it in the same way as a 20 or 30-year-old might do. So I'm going to explore some of those barriers as we go through now. So the first one is limiting beliefs. We all hold limiting beliefs around all various aspects of our life. And I heard a great podcast last week from Stephen Bartlett, who talked about limiting beliefs, and he was talking a bit in relation to finances, but the same applies here. And he used this analogy of an ant and a spider on a bit of white paper. And they took a black permanent marker and they drew a black line around the ant and around the spider. And the ant and the spider will both walk up to the line, turn around, try and find a different route, turn around, and they felt trapped by this line. Now we know, looking at it, that line isn't a physical thing. They could just walk over it if they wanted it to. But it's this line has created this kind of false belief that they're stuck within it and they can't sort of venture out of that. And then interestingly, the spider, one of its legs accidentally went over the line. And the moment that happened, it then completely ignored the line. And if it stopped again and then tried to draw another line around it, it completely ignored that too. And you often find that is sometimes when we break through one limiting belief and we can guide someone to show them that a common one is age. They just assume they're too old to start something new. And even myself, I've got that a little bit where I did team sports through school and university, and then just through the nature of some of my work, and I did a lot of weekends, I kind of fell out of team sport. And I'm 38 now, wishing I'd done a bit more team sport. And there's a small part of me that thinks I've probably left it a bit too late to get back into that now. I'll just stick with running and cycling. And then I sort of think how hypocritical it is. So the other argument is time with a young child, but I will get back into team sports and sort of promote do what I promote. But there's another quote that I found that brought up a limiting belief that you might well hear something similar. How do you respond when well-meaning friends offer advice like, you should do what my friend does? They go to physio and their knees have never felt better. They don't seem to understand that bilateral osteoarthritis is a degenerative disease and no amount of therapy will make it better. Now, clearly, as a physio, this caught my attention straight away. Admittedly, got my defensive sort of mindset on straight away as well. And then I took a second to think about it a little bit more and thought, well, actually, no. From someone who's not in the profession, you read that osteoarthritis is a degenerative condition. It's only going to get worse. And you're already in pain. The natural assumption is the pain is just going to get worse as the arthritis gets worse. Why would I bother putting the effort into physio, which is potentially going to make it even more painful? No, thank you. I'll leave that. However, and I won't go into all the reasons why that mindset's wrong, we all sort of know that, but say this person eventually does get to the point where they just, to shut their friend up, they say, okay, I will go and see your physio, and they come in, and we then treat that person exactly the same as the person who has had physiotherapy in the past. They had a really positive experience with it. They've come in open-minded to the idea that physio is going to help them. If we treat those two people the same, regardless of what exercise, we're not even at the exercise point yet. If we don't explore that person's skepticism around physiotherapy, around exercise, their beliefs of their condition, we're not going to get very far with them. And all it takes us to be a bit too adventurous on our first session with exercise is they get a slight flare-up. We've lost them, and we've lost that opportunity to guide them in a different direction and actually teach them that we can calm that down. And again, she might be right, for her it might not work, but we can certainly make a positive difference in some sense if we take that approach with her. And it's not a groundbreaking question by any means, but one that I like to ask at the end of my subjective is, what are your expectations of coming in for physio today? What are you expecting? And then maybe go on to say, what do you believe can happen as a result of coming in? And questions along those lines can really open up their beliefs, because the person who believes in physio will often say, well, I'm assuming you're going to give me some exercises and I'll do those and then we'll progress them, and they know how it works. But the other one will probably tell you, if they might be honest with you and tell you that, yeah, they're not here for them, they're here just to please a friend and they think it's a waste of time, but we'll give it a go and see what happens. And it's a bit like Andrew was saying in the last talk, that's where we don't jump straight into the exercise, if we do a bit more education and reassurance first before we get into that point. Then their people are also going to have some negative experiences with exercise, with physio, with rehab professionals, like the woman at the start who just felt like she was being dismissed all of the time. We need to try to explore some of those negative experiences, because if we go in and they feel like we're just making the same mistakes or we're pushing them down the same path that they had that negative experience with in the past, again, we're probably going to lose them and lose that ability to change their direction there. And one of those might be, I just undid months worth of progress attempting deadlifts. They weren't even heavy. I was just showing someone good form. I may have messed up my back on the last rep. I won't ever be doing deadlifts again. Now, this is a common one, I think, here. People, the ones who are doing exercise or are going to the gym, tell me that they proudly say, don't worry, I don't do squats because squats are bad for my knees, or I don't do deadlifts because it's bad for my back. And then you've got like a negative belief around those exercise types. And it's our job to try and guide them and say, well, actually, squats and hip hinge type exercises like the deadlift are common functional movement patterns that you do on a day-to-day basis, or not necessarily day-to-day, but we might lift a heavy suitcase to get into the back of the car, or we might have to lift that heavy plant pot and move that over, or even grandchildren. When you sort of tell people the average weights of children at various ages, this suddenly puts things in a different reference point. Because if I say to someone, and it's back to that kind of limiting belief, I've shown them a 12 kilogram kettlebell on the floor, and they look at me and almost laugh at me like I'm stupid that they could even consider that they could lift that up. And then you go on to explore and the fact they've got grandchildren, and I think it's the average 2 or 3 year old weighs about 12 kilograms, and they're lifting up multiple times on the days that they see them. And suddenly it opens up the idea, well, that actually, maybe I can do it, and then they do it, and then suddenly, well, if I can do that, what else can I do? But again, we need to teach them that we need them to prepare their bodies for those heavy weights that they are lifting up already. And the more deconditioned they get, the more chance they might get that might cause a problem. Then we come on to some physical restrictions. So when we're teaching strength training and trying to get increased muscle strength as the outcome of an exercise, we really want to take the targeted muscles to the point of fatigue or point of failure. So the last repetition that we do is the last repetition that we could have done. Ideally, that's going to be within 15 repetitions, and I tend to get people comfortable, not necessarily a failure straight away at 15 repetitions, then we increase the resistance, then they start to get comfortable exploring exercising to fatigue at 15 reps, and then over time I increase the weight to reduce the fatigue point to maybe 10 to 12 reps, then 8 to 12. And the closer we can get it to 5 or below, that's where we really get the most strength gains in our exercise. But you need to use a lot more weight for that, which is it's daunting for a start, but equally for someone whose body's not ready for it, it can cause a flare up of pain or could cause some other problems. So what we want to do, what I tend to do is start with 15 and gradually build backwards. Now, the physical restriction we might find with someone is that they have weakness in a muscle. We do an exercise, they struggle to do it because their muscles fatigue. Fantastic. We've now got a chance to manipulate the reps and sets of weight to push their muscle to fatigue, let it recover, push it again to fatigue, and that way it's going to get stronger. However, particularly with older adults, but this could be true for anyone, any of the following can be the limiting factor before we get anywhere near muscular fatigue. So that could be pain. We could be doing squats, and after 5 squats, the knee has just become so painful that they can't continue. It's not because we reach their 5 rep max in terms of what their muscle strength can do. It's because their knee was too painful. So we're going to have to adapt the way we teach the squat movement pattern. And I'll come on to some of the adaptations towards the end. But that's a limiting factor. So we are working to the lowest level and building up to the point that hopefully we can get to muscular fatigue. It might be confidence. Now there's a psychological confidence side of things, but there's also the body almost locks up sometimes with confidence. So sometimes if we're doing a free weight or a free squat, there's a kind of point where they just get stuck. The body won't let them squat any lower. However, if I put a chair behind them and they do the same squat, partly conscious, partly subconscious, but often you find they can squat a lot deeper because of the safety net of that chair being there, and they know they're just going to drop into it if they need to. But you often find there's little tricks like that you can create a safe feeling environment around the patient during an exercise that allows their body to move into movements that it wouldn't if they just don't feel safe, because our natural reaction is to stiffen up when we don't feel safe. Some people, you'll find it shortness of breath. Some people are going to come in with various respiratory conditions or just a really low base level of fitness. And if I'm trying to get them to their sort of 15 body weight repetitions of an exercise, they actually find that they just can't get in there because they're so short of breath. They have to stop for a second, have a breather, and then start again. And effectively, they've just done 2 sets of smaller, maybe a set of 7 and a set of 8, rather than doing 1 set of 15. So again, we might need to adapt around there. Then we've got fatigue. Some people, it's not fatigue in a muscle, but it's just generalized fatigue. And whether it's actually in that set or whether it's later on in the workout, or whether it's just the next day, they're just wiped out for 2 or 3 days. When they come in the next day, they don't really want to, they're not going to want to keep doing that if it keeps happening. So again, we might need to adapt around that. And there's joint stiffness. So they might not have the mobility to get their shoulder in a position to grab a bar like this. We might need to adapt around there. They might just not have the joint range of motion to do the exercises that we're asking them to do. Then it brings me on to the biggest learning curve I've had in the last 5 years, is just how impactful going through menopause and being postmenopausal can be. And just out of interest, easy question to start with, how many people, with a quick show of hands, how many people feel that they treat someone who is currently at the age where they could be perimenopausal or postmenopausal? So yeah, vast majority of the room. How many people in the room have done any formal CPD courses on women's health related courses? Again, just show of hands. Perfect. And then out of interest again, are there any males in the room that have done any formal CPD courses on women's health? So 1, 2, 3, 4. So very few, given that the vast majority have all said that we treat people, maybe not for women's health problems, like in terms of what I used to consider is that it had to be like a pelvic problem and they needed the women's health physio. And if that wasn't the case, then it had nothing to do with me. And I didn't feel it sort of that blunt about it, but I just didn't even consider that there were other things that might have an effect. So it's something I would consider, and I witnessed it when I watched the menopause movement. Christian, she was doing a talk earlier on, and again, packed seats, standing room around, and I counted myself and 5 other males, and everyone else was female. So again, I think I encourage everyone, but particularly males in the room, it is our responsibility to learn about this as well. So I've mentioned fatigue a little bit as well. Often a lot of the people I work with, that is their limiting factor. Whether it's fatigue during the session or whether it's fatigue after the session, that is what is their biggest barrier to getting into any form of exercise, is if they already feel tired, I don't want to do any more exercise and feel even more tired. Then there's tendon pain, and Christiane was talking about estrogen, and estrogen is amazing for tendons and muscles and their recovery. As we lose that estrogen, our tendons start to lose the ability to recover, and we're more likely to get tendon pain. If we couple that together with the fact that a lot of women suffer with weight gain during menopause, we've now got increased load on the tendons that are not recovering as well. And often that increase in weight gain comes along a psychological desire to want to exercise more to try and do something about it. So we're now increasing the load on those tendons even further. They then end up with a tendinopathy, and it completely wipes their confidence out with exercise, and it creates this kind of negative downward spiral of their association with exercise. Last year I went to a fantastic talk by Michelle Lyons that was on the STA stage, and she talked about exercise adherence and particularly post and perimenopause. And if we look at the physical activity guidelines, so as a quick recap, 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise per week. And for 18 to 65-year-olds, it's 2 sessions of muscle strengthening per week. And for over 65, it's actually 3 sessions of muscle strengthening per week. As a general population, we're not very good at meeting those guidelines. But interestingly, the demographic that fell short the most was women between the age of 40 to 60. Now, some of those reasons were that she referenced a paper. 1 in 2 women who didn't meet those guidelines stated that they had concerns about bladder control. 1 in 3 said they had concerns about the symptoms of pelvic organ prolapse. And 1 in 4 had concerns around bowel control. And then she went on to reference another paper that showed that women who lifted less than 15 kilograms reported more symptoms of pelvic organ prolapse and bowel control than women who lifted 50 kilograms or over. So that's less than 15, 1-5, and more than 50, so 50. Normal school of thought would be, if we go heavy loading, we're going to increase the intra-abdominal pressure, and with a pelvic floor we haven't got the confidence in, we're going to cause ourselves some issues here. I'm going to put myself in this camp, lift less weight, do maybe more reps, maybe just do body weight, and I'm keeping myself safe. I'm probably doing myself a favour here. And yeah, what we're finding is actually the other is true. And I'm not suggesting you suddenly go and chuck 50 kilograms on your patients straight away, but we want that education that actually the thing that's stopping you from getting started is probably the thing that's going to help you. And we want to guide them towards that. But that's going to take education, reassurance, and listening to the patient as we go through. Hot flashes, very similar. She referenced another paper that showed they took perimenopausal women who were suffering with hot flashes, who had never trained before, put them through a 15-week strength training program, and at the end of that program, the incidence or frequency of moderate to severe intensity hot flashes reduced by 44%. But again, you're suffering from hot flashes or hot flushes. Exercise is going to make you hot and sweaty. It's not particularly appealing, so it stops people from wanting to do it. But actually the thing that's stopping them is the thing that could improve. So we've recognised there's lots of different barriers and challenges that people face. We are going to have to adapt our approach, because if we treat everyone like we do in our 20s and 30s, we're probably going to leave the patient feeling like that woman at the start, where they just feel dismissed. And it's not an intentional thing that the personal trainer did. They thought they're probably doing a good thing. Is some people kind of build their careers off being a bit more like a drill sergeant, and they feel like you have to push. And they did it with the best intentions, I'm sure. But 90% of people that might work for, but a lot of people, you're going to feel like you're not listened to. You're going to feel dismissed, and you feel like you just want to give up with it all. So I've talked a lot about the psychological side of things, and so I'm not going to go into too much more in terms of specific adaptations there. But I think the big takeaway from that side of things is we want to make sure we really explore in the subjective assessment. We want to make sure that we know what limiting beliefs they might have, what previous experience they've had with other rehab professionals, with exercise, and how that's related to their pain or other symptoms. We explore, if they're female, things around menopause, ask them about fatigue, ask them about things like bladder and bowel control, at least their feelings around it. And they might open up to you straight away in the first session. But when I was earlier in my career, in my 20s, people didn't open up to me off their own back. It's only since I've learned more about it and I start asking the questions that I actually learn the information from the patient, and then I can adapt my approach. Because I was just blind before. I didn't know what I didn't know. Try to treat everyone the same, and the people that I didn't see, I probably thought they got better, but it's probably that just found someone else that was listening to them. And the reason I've kind of used the steps there is that these kind of bigger steps here, that's a normal approach you can maybe take to someone else. You can take a big step up and then spend a bit of time doing that, big progressions again, and you can get away with those. Whereas often, if we're struggling to get someone started, it's because we haven't made the first step small enough. And if we're struggling to progress, it's because we haven't made the step of progression small enough. So lots of little steps, it might take longer, and we might need to explain to the patient this is why we're doing it, because if they feel like they're all these little steps and sometimes they feel a bit bored and disencouraged with it, we have to explain that no, we are going to get to the same point. We do have this bigger vision in mind, but yeah, small steps along the way is the main take. And yeah, you just want to make sure the patient feels safe in your company. They know that you can listen to what they're telling you and you're going to adapt each session around it. And I work with a colleague, Dan, who at the start of every session, no matter if he's only seen him once or twice or we've seen him for years, first question, how are you feeling? How are the energy levels? What do you feel up to today? And he will adapt his plan there. He won't necessarily change the whole workout, but if he was planning on doing a personal best at some point soon, he's not gonna attempt that on a day where they say he's got low energy, because they're just gonna feel guilty and bad about themselves, and they feel like they let you down because they tried to do it and they couldn't do it, and then they flared up, and then you feel guilty that they feel flared up and down about the whole thing. So yeah, small steps there, and I just listen to what they're saying. And then some more practical ones, and I won't go too much into this because this is what everyone's already good at, but the things that we might need to adapt our exercises and our workouts in the sessions with our patients is around pain, confidence, shortness of breath, and fatigue. So pain, I've got a separate slide in a second. Confidence, it's that making them feel safe in the environment around them, having safety nets in place, whether that is a chair behind them, whether it's them doing a bench press and you're stood over as a spotter, ready. Again, if they know you're there and you're not a few steps away and you're right in front of them, that helps them go for that last repetition. You have these arms that come out of squat racks that when they squat down into it, it catches the bar. It might be that we change the weight we're using. So rather than a barbell, we might use dumbbells, or we might use a weighted vest. Fixed machines are great because people aren't going to fall on a fixed machine. So they can actually get used to working against resistance of a fixed machine first, and then my bias and my preference is get people back towards free weights afterwards. But we want to create a safe environment. Shortness of breath, rather than me taking them to 15 reps and then really trying to push them, bring the weight up to bring them down again, if they can't get to 15 body weight repetitions because they're so short of breath all the time, I might just start at 6 reps. And then rather than even worrying about getting anywhere near 15, I just keep it at 5 or 6 reps and add a bit of weight and add a bit of weight and take a bit more time there. But I might need to break up the number of reps and sets and increase the rest in between around that shortness of breath and the recovery around that. And fatigue, rather than doing one workout of 4 or 5 exercises, I might just do one small workout with 1 or 2 exercises and then do a bit more frequently throughout the week. But again, we can manipulate that side of things there. And then we come on to modifications around pain. So things like depth. So rather than doing a deep squat, I might just do a shallow squat. And then rather than load, and what a lot of people don't do is once they've found that they can tolerate a shallow squat, they just work at that and gradually over time try and do a deeper body weight squat. But actually you can load the shallow squat really heavy, more heavier than you think, without going over that threshold of causing knee pain or causing pain anywhere. Build their confidence in lifting heavy weight, and then you can then drop the weight and bring that down so they go through into a deeper. And then we talk about the different types of weights and resistance. So again, someone who's in pain and they're not doing squats, you might put them on the leg press. And with a body weight squat, the least we can do is your body weight. But on a leg press, I could drop it down to 10 kilograms, and I can get them doing a squat-based action in a much more comfortable range of motion. And then I can then up the weight till eventually their body weight and doing that. I've talked about fixed machines there. We can change the angle. So rather than doing shoulder press here, I might do incline, bench press, and then a much more comfortable range. Or I might change the tempo of the exercises. But this is the things we're already good at anyway. The big takeaway is listen to what your patients are telling them, explore their subjective, get to know them and get to know their fears and their belief systems before you even give them an exercise to do, because that's going to make the biggest difference, particularly with those that are older adults.